hear myself echoing. So as Benet said, I am an interventional radiologist up in Milwaukee, and so I have a very unique place in this world. So I trained in University of Pennsylvania in Philadelphia, and I did 2 years of surgery, 2 years of diagnostic radiology, and 2 years of interventional. So I always knew I wanted to be an interventional radiologist. So what does that mean? What do I do? So I use imaging to do procedures and treat patients. And my true love, is doing interventional oncology, meaning I use imaging to guide me to treat cancer. Okay, so we're going to go through a bunch of cases. I think that's the best way for you guys to see what we do and how we use imaging to help us as clinicians. And then we'll sort of talk about the emerging technologies that you guys will hopefully see come to fruition and mainstay. Does anyone know what this picture is? I showed my husband, he thought it was my hand. Okay, it's not my hand. I was very insulted when he saw this. Okay, so this is the first radiograph ever taken. Okay, Wilhelm Röntgen in 1895 was playing around and go through learning objectives, just basically what I said. This is Röntgen here. Okay, in 1895 he was messing around and he figured out that X-rays exist, and he actually took a picture of his wife's hand, and that was the picture that you saw there. Current imaging modalities we use, okay, so there's X-ray, which we attribute to Dr. Röntgen, and with X-ray we can do a lot of things, okay? We can do mammography, we can do fluoroscopy, angiography, and we'll get through what all of these things are, and CT, computed tomography. Other imaging modalities that have come down the pipeline are ultrasound, which we use every day, MRI, which I'm sure you've all heard about, and then nuclear medicine has been around for a long time, and I'm going to show you pictures and examples of each and every one of these things. So tumors. So I'm supposed to talk about tumor imaging. So what's a tumor? Tumor derives from the Latin tumere, and I'm probably not saying that correctly, and it just means to swell. And my definition is it's just basically an abnormal cell, and he gave a fantastic talk about what is abnormal. And they're different flavors. So there are benign tumors. There are tumors that you can have and you can live for your entire life and they don't kill you. And then there are malignant tumors. And malignant tumors are things that will eventually lead to your demise. Here's a histology picture, just because we know the next speaker is going to talk about that, showing a abnormal tumor here and normal. So this is what they look at under the microscope. I can't see that with imaging. And this is what gross pathology looks like. Tumors are just basically different than the surrounding tissue. And my job as a radiologist, so not the treatment part, but just the diagnostic part, is to be able to see that difference. And how can I see that difference? Well, tumors have different characteristics. They swell, they can get big, they can require more blood flow, so they can be hypervascular. They can outgrow their tumor supply or their blood supply, so they can be hypovascular. They just have to look different enough from the surrounding normal tissue that I can see it with my eyes on imaging, okay? So plain film, good old plain film that Dr. Röntgen you saw in 1895. So these are two X-rays. So if you guys can't see the tumor, tell me, okay? I was a medical student and could never see the tumor, and I was going into radiology. So if you can't see the tumor, tell me, and I will tell you where the tumor is. But essentially, these are two radiographs, okay? The image, this one, they're both osteosarcomas, and they come in different flavors, cancer. So this one you can see, this is a tumor here, this is a femur, so the thigh bone, it's right here where you're looking at it, and that's a big tumor that's making more bone, essentially. This is the same type of cancer, and you can't see the tumor, right? You just see no bone, okay? That tumor has chewed through the bone, there's no bone left, and that's the tumors. But I can make that diagnosis on this X-ray because I can't see that bone, it's destructed. And some lesions are the one on the right, and some lesions are sort of more the one on the left. Mammography, okay, it's just another X-ray. We put women in machines, we compress their breasts, and we take pictures. So what does a normal mammogram look like? Well, it sort of looks like if you take this part of the screen. But this spiculated mass, this density that I can see, that sort of looks like somebody crunched it or pulled on the tissue, that's what breast cancer looks like, okay? So we have a bunch of people sitting in a room, and they see something that looks abnormal. Now, calcifications is what we typically talk about with mammograms, and back in the old day, we had these magnifying glasses that we used to use. Now we have these fantastic computers that we can just click a button and magnify things, but this is pleomorphic calcifications, which is very typical of what we'll see in breast cancer, okay? They're dots. I'm telling you, they're dots in an X-ray, and you have to be able to see a dot on an X-ray, but it's different than the surrounding tissue. So that one dot can be enough for a mammographer to say, you know what, this doesn't look right. You need to come in and get a biopsy. This is angiography, okay? So angiography is basically taking, I'm going to flip to fluoroscopy for a second first. So fluoroscopy is basically you have X-ray and you just have a pedal, and that X-ray is going to be continuous. Okay? You can take a picture, and you can stop and take a picture if you want, but basically what's happening is you're just continuously having X-ray. So you can move your hand in and out of the beam, and you can see your hand moving. And so what we do for fluoroscopy is we do barium enema. We image the bowel. So what we'll do is we'll have people drink barium. Okay, you can see barium on X-ray. And then what we do is we call it a double contrast study. We give them air. So we infuse barium in, and we do this from behind, and then we infuse air in, and you can see the double contrast, the air mixed with the barium. This is an apple core lesion right here. Okay, this is normal. I just wanted to show you just what a normal colon looks like. That's what your colon looks like. Okay, this patient is actually laying on their side, which is why you see those lines of barium layering. But this is an apple core lesion. Do you see how it sort of looks like you chewed around an apple? That's what colon cancer looks like. Colon cancer invades into the wall of the colon and makes it look different. All we had to know is it looks different than the rest, and we knew this was cancer. Here's another barium enema. And you can just see, this just doesn't look right. What's this circle thing? Okay, that's how we used to make the diagnosis of colon cancer before we had colonoscopies. Now we very rarely do barium enemas because barium enemas can make a diagnosis, but they can say there's something abnormal, but we can't make a diagnosis per se. We usually know it's colon cancer, but we like to do other testing on it.
Excuse me, what's the scale of that picture?
This tiny thing, what's the scale?
Yeah.
Oh, it's really magnified, so you can see it. It's probably 20 times magnified. It's pretty big. So that's probably a 1 centimeter lesion. Now, angiography, there was a very smart man, Chuck Mistrata, who decided that angiography is basically doing real-time X-ray. So my pedal, the X-ray is coming continuously, and I'm injecting contrast. So contrast is something like barium. I can see it. The problem is when you inject contrast, you have bones in the way, especially if I'm going to be looking at organs in the mid-region, so your kidneys, your liver. And so what he decided was maybe I can subtract the X-ray from all the other images so I only see contrast. Okay, he's like, let's try it. So he did. It's called digital subtraction angiography. I use it every single day of my life. Okay, this is a picture from a digital subtraction angiography. We took a picture, and then we subtracted every other image out. So you can imagine if the patient breathes, you're not going to get a beautiful picture because the subtracted image isn't going to match up with the picture that you have on the screen. So this is a kidney. I have a catheter here. This is my catheter coming from the groin. You get into the artery of the leg. You go up, and you use a catheter to select the renal artery, meaning you put that catheter in the renal artery, and then you inject contrast. You step on a pedal, that same pedal, and the machine knows how to do it now. One pedal for fluoroscopy and one pedal for digital subtraction angiography, and I get this beautiful picture. And as you can see, this top part is what a normal kidney looks like. This is an abnormal looking kidney. Okay, it just looks different than the normal kidney. So this is how we used to diagnose tumors before we had fancy CAT scans or MRIs. And this is a renal angiomyolipoma. Okay, this won't kill you in that it's not cancer, it is a tumor. And if it gets large enough, it will actually rupture and you can have bleeding. So we treat these just to prevent bleeding. CT scans, okay? Everyone knows them as CAT scans. And this is a CAT scan of the head. Okay, so one of the guys that trained me actually started reading the very first CAT scans in Boston. They had no idea what they were looking at. Okay, a CAT scan is basically an X-ray, and it goes around in a circle. And then they reconstruct the data to make it look like a 3D or 2D object. Okay? And he said, we didn't know what we were looking at. We had no idea. We were like, oh, I don't know, that looks weird. I don't know, is that normal? Is that abnormal? Because there's a lot of variation in normal. Okay, this is not normal, I'll tell you. This is a big brain cancer. This is glioblastoma multiforme. It's just it's a brain tumor. And this is what a CT scan looks like, and you guys have probably all seen these. They have them on the news these days. So ultrasound, you guys have probably all either seen an ultrasound, had an ultrasound. Ultrasound we use all the time, okay? There's no radiation involved. We don't have to use X-ray. We use this in children a lot. We use this in the female pelvis because it gives us a nice, clear view of things. This is an ovarian cancer. How we do ultrasound is we basically send waves, and then the waves reflect back against tissue. So if I wanted to ultrasound the lung, you can imagine it doesn't have anything to bounce off of. So I can't really see the lung. But if I have fluid, if I have organs in the way, I can usually see things. And we'll go through more examples of ultrasound than just this. And then we get to MRI. Okay, MRI, was also came through the pipeline, I think, in the 70s, and this has just changed the way that we practice medicine. MRI is basically we put patients in a magnet, and then we change the magnetic field, and basically how the atoms in different tissues respond to magnets differently. And then that gives them a signal, and we can read that signal. So this is a cardiac MR. Okay, we can look at the heart. We can find tumors in the heart. The machine is smart enough to know I'm going to turn on, and I'm only going to take pictures during this phase of the cardiac cycle. I mean, this is amazing stuff. And this patient actually has a tumor. This is the left ventricle, so this is the muscle around your heart that squeezes, okay? And it just looks different. Do you see how this looks different than the rest of the muscle? That's all we had to do as radiologists to say, that doesn't look right. Okay, so that's a septal hemangioma. And then we have PET scan. Okay, this is a nuclear medicine study. We use glucose. We know that tumors turn over very quickly, and in order to turn over very quickly, they need glucose to metabolize, okay? So we decided that we were going to label that glucose with something that we could see an image. And so we labeled it with F18, and we get these beautiful pictures. Anyone want to guess what this is? I'll give you a hint. You guys sort of had a talk about it before. So this is lymphoma. Okay, this is when those red blood cells aren't swimming around your body, but they go to the lymph nodes. So this is a patient that has Hodgkin's lymphoma. And then we have thyroid scans. So if you want to look at patients that have thyroid cancer, we give you I-131, which is just iodine that we've made radioactive, and we give it, and you can actually see thyroid tumor light up. You see that big star? That's just because there's so much of that radiotracer concentrated in there that you can see that. We actually give I-131 to treat thyroid cancer. So not only can we make the diagnosis, but we can also treat you. So if we give you a very tiny little bit of I-131, we'll get the diagnosis. If we give you a bigger dose of I-131, we can actually treat you, and it goes everywhere. It can treat metastatic disease, not only the stuff in your neck. Very typically, we do this after patients have had a thyroidectomy. The thyroid bed usually has these teeny tiny cells that we can't see, and they go back in, and we give you I-131. So now we're going to start with our cases, okay? So first case, this is actually my patient. He was a 34-year-old male, and he was in a snowmobile accident. And because he was in an accident, he was having some belly pain, and he said, I think I need to go to the ER, and they scanned him. They said, well, let's see if he has any injuries, okay? He was asymptomatic. He had no symptoms. He didn't know anything was wrong with him. So they get a CT scan. Does anybody see anything wrong? So we're looking now at an axial image, so I've cut you like this. Okay, we're at the level of the liver. So this is the back, this is the backbone. These are your ribs. This very thin line is your skin. This is your liver. This is your stomach. This is your spleen. Okay, so does anyone see anything that doesn't look like the things surrounding it? So this, right? There's a black hole in the middle of the liver. It's not, I mean, it's just, what's that? Okay, that's what they said. Well, what's that? He's 34. Is this normal? It doesn't look normal, okay? You can have benign things that we know after looking at these CT scans for years and years and years that are normal, and you can have them just, you had them as a child and it doesn't matter. But this doesn't look like that, okay? And he had a couple of them. You look over here, whoops. You look over here, this doesn't look right either, right? This is what normal liver looks like. It's sort of smooth, you know, sort of this gray color, and this kind of is looking more black, has a border around it, and this just looks weird. This just doesn't look right. And a lot of times when I was in my residency, I would call my attending and say, I don't know, it just kind of looks weird, okay? And that's how, when we have to use big words to describe weird, but that's oftentimes how we'll make a diagnosis, is something looks weird, and then they biopsy it, okay? So we ended up biopsying this. They said, I don't know what this is. Let's biopsy it. Totally asymptomatic, no symptoms at all. He's got an 8-year-old daughter on a snowmobile and crashed. So here's ultrasound, okay? How do we get to these lesions? We put an ultrasound probe on. Can I see it? Yep, we could see it, and we just put a needle into it. So how do I know I'm in the needle? Because I'm watching. Okay, ultrasound is real time. As I'm advancing the needle in, I can see it go. I can see that I'm in the middle of the tumor, and we get the diagnosis. So this patient had carcinoid. Carcinoid is a tumor that typically starts from the small bowel. Well, we did a CT scan. We imaged the bowel. How come we couldn't see it? Because we ate food, right? Okay, so you eat food, and there's a bunch of stuff in your intestines. It's very hard for us to see the intestines because they're also peristalsing, right? They're squeezing and contracting, so it's very hard to see. So we could go back to our fluoroscopy, and we could do a small bowel follow-through, right? We could drink stuff and watch it and see if we see anything abnormal. That takes a lot of time. We don't typically do that anymore. So what we can do now is we have patients drink water. So we have them drink like a liter bottle of water, and we say, drink that. And then we'll do a CT scan. It's called CT enterography. Enterography is the word when we would just swallow the stuff and take x-ray. This way we can do a CT scan and we can see what part of the bowel has the cancer. So this is basically a CT scan axial image, and now we're down here, just about the middle. Does anyone see anything that looks abnormal? Now you can window these scans too, so you can make it darker or lighter just depending on what you want to look for. Does everyone see this thing? Okay, this is what water looks like in the bowel, sort of this light gray color. See this bright white dot? I sort of windowed it here to make it even more apparent. Okay, that was his primary tumor. So we used imaging to, one, make the diagnosis in an asymptomatic patient, and two, use imaging to guide us to biopsy it to actually make the diagnosis, which the pathologist did. And then we went back to imaging again to say, okay, now where really is it? Because these are just metastatic implants, so the cancer has spread to the liver, but we need to find where it came from. They found it, the patient went to the operating room, and he had this cancer resected. So they took out a small bowel, and then he came to see me in the interventional clinic. And we wanted to talk about the liver disease. This is an MRI. Okay, we can image in different planes. We don't have to just image in the axial plane. Here we're looking in the coronal plane, so if I cut you like this. Okay, so up top here, this is his heart. Okay, this is his liver, kidneys, spleen, and his spine. So does anyone see anything that looks abnormal in the liver? Yeah, right, there's two big things there. So what are those? Those are what we biopsied. Okay, that's his cancer that's now in the liver. So I can go after that and treat that. So how do I do that? What we talked about before. So with MRI, we can also do other types of imaging. We don't just have to use contrast like we do with CT, but we can look at the water density of things. And when we actually looked at the water density of things, this is called diffusion weighted imaging. Does anyone see anything that looks abnormal in the liver now? They're light bulbs, right? They're white light bulbs, those little white dots. Well, what are all those things? That's not what the rest of the liver looks like. So he has these tiny little implants. So if you looked at the prior image, it looks like he's got two big lesions and we're done. But if you look at the diffusion-weighted imaging, so the more sensitive sequence to cancer, you can see all these little dots. So he has disease everywhere. It's all over his liver, okay? So then they bring him to see me, and they say, can you fix him? And we said yes, okay? We're getting there. The other thing we can do is to see if he has disease anywhere else. So we treat these patients that have neuroendocrine tumor with octreotide. And octreotide, we can do an octreotide scan. So basically, like we did the PET scan before, or we did the thyroid scan before, we can couple a radiotracer to octreotide, and that will only go to cells that make octreotide or have this receptor on it. And so we did an octreotide scan to see where else does this guy have disease? Does he have metastatic disease everywhere else, or is it just in the liver? Turns out, as you can see, it's just in the liver. Okay, some of these radiotracers go to other places just because they do. We know they go there, and so that's not abnormal. But you can see these bright light bulbs again. This is his disease in his liver. So now we get to me. Got a little eager there because I like to treat patients. So here's my catheter. Again, we're using digital subtraction angiography, and you can see, everyone see this? This is what normal liver looks like on angiography. Okay, you should just see these beautiful, beautiful, they look like roots of a tree, very straight, very sharp. And you can see when you look up at the top of the image, they're squiggly, they don't look right. You can even see a little one here, right? So that's probably one of those small tumors we saw on the DWI imaging. And here you see these big, almost look like cannonballs in the middle of the liver. So those are his tumors. Okay, I injected chemotherapy directly into those tumors. And I actually mix my chemotherapy with oil. We knew back in the 80s, actually way before that, I think 1906 was the first time they used oil. And that actually, the tumors take up that oil and it stays in the tumor, it retains it. So one, we can see that the drug got there, but also we can see if the tumors take up that oil, it means they will have a better response to therapy. So this is what it looks like after. We're back to that CT scan. Now does anyone see anything abnormal? Right, there's a bunch of oil. Okay, all that white stuff is me. I injected all of that stuff in. Looks like I made a mess, doesn't it? Well, that's what it looks like, okay? You go to the territory of the tumor, and then you just inject, and it goes where it goes. And you can see here's the tumor. So I'd wish the tumor looked like a light bulb, because that would have meant that it all went to the tumor, but it actually goes to the normal liver also, okay? And so this is what he looked like after we treated him. This is a couple months later, okay? It's retaining that lipidol. That means that this patient, that drug got taken up into those cells, and those cells are just holding on to that stuff. And these are a sequence of images. This was before. Now we're back in the axial plane. This is about 3 months after, and this is about 6 months after. So do we think I did a good job? Who knows? How do we know if we did a good job? So we've come up as radiologists and clinicians with a whole host of response criteria. So RECIST is what we like to talk about, and we'll talk about what RECIST is. But do you look at tumor necrosis? Do you look at enhancement, so how much contrast the tumors take up? So we sort of don't really have a good idea, none of us have decided that this is the best way to image tumors, okay, especially with all the new therapies that are coming down the pipeline. Lipidol retention, functional imaging, do we look at PET, or do we look at tumor markers? And so RECIST criteria is the response evaluation criteria in solid tumors. And basically, if it's a response, it is a decrease in the maximal tumor diameter by 30%. So your tumor has to get smaller. Okay, we're going to go through another case later where the treatment I give kills the tumor, but it doesn't shrink it. So this doesn't apply to that. Okay, so that's why we don't really know how to say tumors respond or not. What's the scientific basis for RECIST? So if the tumor has decreased by 30% or grown by 20%, the change is equivalent to 50% change in tumor volume. So if you actually look at the volume of the tumor. It also statistically correlates with patient survival if you look at that change. So how did we get to this? Basically, a bunch of oncologists sat in a room with a mattress. And they had these little tumors that they put in the mattress. There's the oncologist, and they measured them. And they said, is it reproducible? Is you measuring reproducible? And they found out that it's not so reproducible. And so that's sort of how we figured out, of those 16 oncologists that measured those 12 spheres, the size range was small, which is what tumors would be, 1.8 centimeters to about 14 centimeters, and there was a lot of errors. So that's sort of how we came up with, we're allowed to have errors as radiologists if the way I measure is different the way you measure, different than the way that the guy down the street measures. It also matters how we breathe. Okay, when we breathe, unfortunately, our diaphragm does this, our liver does this. So depending, if I take a deep breath and you image me, my liver's going to be in a much different position than if I exhale, my liver's going to come up. Okay, so all of those things come into account. So they let us have a little bit of variability in what we image, in what we call response. So basically, if you're plus or minus 16%, we call you stable. If the tumor is plus or minus 16% of what it was on the prior scan, then we say stable disease. And as cancer doctors, stable disease, we pat ourselves on the back. We like stable. We don't like progression. We don't like it to get bigger. And getting smaller or going away is obviously the best thing we can do. So did this patient respond based on that? He sure did. He sure did. And so we actually referred him to our transplant center. We knew he didn't have extrahepatic disease, but on subsequent imaging, we saw Ditzel. Okay, we saw something right where they had resected him. It was a little dot. We said, we don't know if this is cancer or not. The transplant surgeon said, we'll transplant him if you can prove to me he doesn't have extrahepatic disease. So do we try to stick a needle into a Ditzel? Do I try to get my ultrasound probe and go swimming around in a millimeter? No. So we didn't. So we went back to imaging again. Let's do a PET scan. Is anything hot on PET? So we didn't see anything hot on PET. This is probably the liver tumor that we saw before, still some activity. And we did our Octria scan. And you can see there's only uptake in the liver. So he does not have extrahepatic disease. The only disease he had were those foci that I treated, and now he's on the transplant list, and hopefully he'll get transplanted. And we're still waiting to see what happens to him. Case number 2. We have a 68-year-old man, alcoholic, essentially drinks 10 beers a day, and he did that for 40 years. Okay? He came in and he had blood in his urine. Okay? And they did an ultrasound of his kidneys. They thought, well, maybe you've got a cancer, maybe you've got a kidney stone, let's see. So this is the liver, okay? When you're doing the kidney sits right in the liver, so they kind of put the probe and they're like, whoa, what's that? And they get this. The problem is when you drink 10 beers a day for 40 years, your liver becomes fibrotic and you get something called cirrhosis. And I'm sure you've all heard of cirrhosis. So when you get cirrhosis, what happens is the liver stops functioning. And when the liver stops functioning to its full capacity, you can't make, your blood gets thinner because you don't synthesize the factors you need to make your blood thick. The other thing that happens is your platelet count goes down. So we see this tumor and we think, well, we want to biopsy it, right? That was what we did in the last case. It's something weird. We want to biopsy it. Well, these patients are the worst patients to biopsy because their blood level, their blood is thin. So you stick a patient in their liver, which is a very vascular structure, they're going to bleed. They're going to bleed and bleed and bleed and bleed, okay? So we don't like to do biopsies. So as imagers, can we make a diagnosis without doing a biopsy? Okay, is there any way that we can just say, this is what it is, I don't need to stick a needle in it? Well, for HCC, hepatocellular carcinoma, liver cancer, primary liver cancer, we can. Okay, this is I think one of the only cancers we can say, yep, 100%, I know that this is what this is. We use tumor markers, alpha-fetoprotein, which is made by these tumors. If that's elevated in a cirrhotic with typical imaging characteristics, it's liver cancer, period. And that's what we did with this guy. So here again, axial images. Does everyone see the tumor? Here it is, okay? So we actually did 2 passes with a CT scan. We injected contrast in his IV in his hand, and we did a CT scan very early. So the contrast was right in his arteries, okay? Then we waited, and we let it go to his veins. When on the arterial phase, you see hypervascular enhancement, so it's very bright on the arterial phase, and then it washes out on the portal venous phase or the late phase, then we know that's HCC, period, end of story. I can treat this, okay? And that's what we did. We made the diagnosis, this is hepatocellular carcinoma, and we said, okay, now what are we going to do? So patients can get transplanted if they have a hepatocellular carcinoma and they're in a certain criteria. So if we know the tumors are small enough and we can get to them, we can treat them. So I took him to the interventional suites. I did an angiogram. Here again is my catheter. Again, using that digital subtraction angiography catheter. Here I'm all the way out into these very small arteries. You can see the arteries just look abnormal. They're sort of spiny and spindly. And if I wait until all the blood clears out of the, all the blood clears out of the arteries, you can see that stain. And that's a tumor blush, what we say, okay? And that's what hepatocellular carcinoma looks like. Got there, treated him, mixed it with that oil like I did the last time. And here you can see the light bulb, okay? So here I was super excited, and I was like, oh, look at me, pat on the back. This guy got staining of the complete tumor. It's going to be great. It's going to die, and we'll, mark this as a success. So what do you think happened? So remember this blue, red, yellow, orange thing? Yeah, so he wasn't one of those. He decided that his tumor didn't like my drug, and it didn't care. It didn't take it up, and he ended up coming back, and it looked like I hadn't even treated him. Okay, so what did I do? So I could try that again. Just say, that didn't work, let me try again. I don't really like to do that. Try it and it doesn't work. So we decided, well, we could do something else maybe. So there's something called ablation. Okay, so you can do cryoablation, you can do microwave ablation, or you can do radiofrequency ablation. So basically what you're doing is you're cooking a tumor. You put a needle in and you can cook it. You can cook it with microwaves, you can cook it with radiofrequency waves, or you can cook it with, or you can freeze it with cryo. So you can put some liquid nitrogen in there and freeze it. Okay, so because that tumor, you can see how close it is to his skin. It's right here. So I decided I didn't want to cook it because I didn't want to cook his muscle because that's probably going to hurt a lot, right? You cook your muscles, your ab muscles, that probably wouldn't feel good. So you freeze it, and freezing doesn't hurt as much as cooking. So we put our probes in, and here you can see our probes. And the beautiful thing about cryoablation is that you can see the ice ball form because it looks different. Okay, microwave, you can't see those microwaves. It doesn't make the tissue look different. So the 2 advantages to doing cryo is 1, it wasn't going to hurt him, and 2, I could see the ice ball forming. So I would know if I was encroaching on those muscles, okay? And here, this is when the probes are in, the ice ball is forming. And here is after I've taken the probes out. This black dot right in the center of that, what do you think that is? This is air in the stomach. That's air, okay? When I shoved that probe in, I introduced air. And we typically see that it's not a problem. And you see this bright stuff here? That's the retained lipidol. He had a little bit retained, but most of the tumor didn't respond. And here we are today. Okay, I just saw him in clinic, I think 2 weeks ago, and this is what a scan looked like. How's it look? The same, right? Does anyone see any enhancement? This is a lipidol, and I'll tell you this is also a lipidol. So we do a non-contrast image, then we do the arterial phase, and we see, is there any enhancement? And there wasn't. It looked exactly the same on both. Does anyone see anything else that looks weird in his liver? Just weird looking. Yeah, right? He's got more disease. Okay? So now he's got disease more places. So what I actually did was I brought him back and I treated him. I think on Monday I treated him. Okay? So now we've seen that we've treated the one, and now we're going after the other things again. Okay? Case number 3. So I don't mean to be depressing. I hope I don't think I'm depressing you all. You have sad faces. No. So case number 3. It's a 50-year-old female with a history of, she had lymphoma. Talk about bad luck. She had lymphoma in 1993. She gets over that. 2000, she has a mammogram. She has breast cancer. So they do a mastectomy. They take off her breast, and they treat her with tamoxifen. And she's cancer-free. She gets on tamoxifen for 5 years, 2005. She's done. I'm cancer-free. She's not. 2010, she comes back, and now she's got disease in her liver. Okay? It's refractory to chemo. She's gotten rounds and rounds and rounds and rounds of chemotherapy, and she's just not responding. So now she's got disease in her liver. Unfortunately for this poor woman, her kidneys are also haven't liked all of this chemo that she's seeing, so her kidneys are failing. She's not to the point of dialysis yet, but when we give contrast, that can cause her kidneys to get even worse. So she comes to my office and she said, is there anything you can do for me? So I said, oh boy, that's a toughie. So this is the only imaging I have, okay? This is a non-contrast CT scan. Does anybody see anything abnormal in the liver? Yeah, so what's this? It's this big blob, right? It just looks different than the rest. Now I can't tell you what it is. I just know it looks weird. I can't give you contrast to see if it's hypervascular, hypovascular, if it enhances different. Is it scar? Is it, what is it? I can't tell you that without contrast. But I can tell you it looks weird, okay? So the oncologist said, this looks weird and it's getting bigger, whatever this weird thing is. So they got a PET scan. And this is what your PET scan looks like, okay? Sometimes we call it unclear medicine because we can't see what we're looking at. It's just a big smudge on the screen, okay? So what we do at the time we acquire the PET scan, we get a CT scan, and we fuse those images together because the computer's smart enough to know these are the same positions of the patient, and we fuse them together. So this is what the fused scan looks like. So this is FDG avid, meaning that it's taking up a lot of glucose. So that's tumor, okay? So what do I do for this patient? Do I try chemoembolization on her? Do I go up in there and treat her with chemoembolization? Well, I sure could, but there's something that might be a little bit better, okay? There's something called Y90, or radioembolization. So we went in and we did an angiogram, okay? And this is what her left hepatic lobe looks like. So the left part of her liver. Does everyone remember that tumor blush I showed you before? Does that look like tumor blush? Yeah, right? The whole liver. Okay, the whole left lobe is tumor. There's not, maybe this much that's not tumor, but the whole left lobe is tumor. So treating with chemoembolization, I sure could do that, but I thought, let's do the big guns. Let's bring the big guns out and let's give her radiation therapy. So the way we do that, we could give her external beam radiation. The problem with that is that you have lots of things in the way of the external beam. Okay, you have your stomach, you have your heart. The left liver is right here. Okay, that's not a very nice place to have radiation. Your esophagus is there, your aorta is there, your breasts are there. Not a great place to get radiation. So we can give little teeny tiny beads in a glass that we coat with Y90, and it's radioactive and it can kill anything, okay? And so before we do that, we just want to make sure that there's nothing else that we're going to kill. Radiation to the stomach doesn't like radiation, okay? So we do a scan first, we do this, and then we inject MAA, which is basically sort of like a dry run. It's a radioactive material that won't kill anything, but it'll tell us where's that going to go. Is it going to go to the stomach? Is there going to be a shunt to the lung? Because sometimes the liver has these shunts that go to the lung. So we injected MAA. And this is what the pictures look like. Okay, I said unclear medicine, right? What is that? Well, this is the liver, and this is the lung. And we want to see the fraction, the shunt fraction. So how much of that goes around the liver into the lung? And her shunt fraction, as you can see, 2.2%. So that means not very much of that's going around her liver into her lung. And you can also see there's no uptake in the stomach. You can't see it on this, but there are other images. So she didn't have any uptake to her stomach. So we treated her. Okay, we gave her Y90. But in order to be able to give her the Y90, I have to know how much to give. I can't just say, oh, I'm just going to give you some, right? Like chemo, you can sort of say, well, this is about the dose. So you have to know how much. So we deliver radiation by volume. So we actually took that CT scan and we parceled her liver up. So I sat in the lab and we actually just cut it into pieces on every single slice as we went through the axial images, cut the liver apart and said, this is the right lobe, this is the left lobe, this is the total liver volume, and this is how much of those beads I need to give a therapeutic dose, and that's what we did. And this is the liver volumes that we've done. She had a very small left lobe in compared to her whole liver, and we actually treated this woman, okay, with radiation. I don't have the results yet to tell you, but I'm optimistic that this actually will work for her. Okay, last case we're going to go through, 68-year-old oncology nurse. She presented with vague abdominal pain, and she had normal liver functions. So this is an MRI. Anyone see anything abnormal that's maybe measured? So she has these huge lesions. Do you see these? Huge, huge, huge lesions. They're taking over most of her liver, okay? So we did a biopsy. Biopsy showed well-differentiated neuroendocrine tumor. So very similar to what the first patient had, okay, this carcinoid tumor. And we looked at the Ki-67. So that's sort of a marker to us to tell us, and we'll go through what Ki-67 is in a second, to tell us how aggressive the tumor is. We did an octreotide scan, which we looked at on the last patient. There was no extrahepatic disease. It was limited to her liver, but they couldn't find the primary tumor. So what is Ki-67? It's basically a cellular marker for proliferation. And if it's less than 3%, and if you go back, hers was 2%, it tells us that it's low grade. That means it's a slow-growing tumor, and she's probably gonna live a long time. Okay, so she had this low-grade tumor. So what did we decide to do? Well, what I'm good at. So we went in, and you can see this. This is probably one of the most beautiful images I think I've seen of a tumor. So it's on a stalk. This is the tumor. Okay, this is a second tumor. We injected our chemotherapy with our oil. Afterwards, you can sort of see how this looks grainy. We've got an uptake. There's no tumor blush left. This is our follow-up CT scan where we can see the little pietal has been taken up into the tumor. And here she is. So the tumor starts shrinking. Okay, as the tumors shrink, we know we're getting good response. We actually got her down so much, 5 treatments she had to have. Okay, she came in, she got 5 therapies, but we got her tumors to shrink so much so that we could resect her liver. Okay, so the surgeons took her to the operating room, they took up part of her liver. And there was those 2 little pieces on that right side, they stuck a probe in the operating room, and they ablated that side. Cancer-free. So we thought, oh, this is a win. Okay, on imaging, we didn't see any cancer anywhere else. This is a win. We've cured this patient of cancer.
Question to that. So
Yeah, sure.
once you successfully shrink the tumor,
Uh-huh.
and I'm pretty sure that the area which used to be occupied by tumor, but somehow you shrink it, kill it. So this part of the regime can operate functionally at the white cell and red, the blue cell, something like that. You know what I mean? So you shrink the tumor, I mean, this big tumor is smaller.
Right, yep.
The outer shell is alive, is a new one.
Is there tumor around it?
Yeah.
There sure could be. In that penumbra, so that area around the tumor, there sure could be. We would usually see enhancement, okay? So
The question is that when you shrink the tumor under the movement of the patient can, the brain still function properly.
oh, is her brain functioning?
Yeah.
Oh, sure. So I'm not giving chemo through her IV, I'm giving it directly to the tumor. So the dose of chemotherapy I'm giving is much lower than if I would give it systemic. So the chemo brain you're talking about, that patients get a lot of chemo and their brains don't work right, it's a very small dose compared to what you would get. And she was functioning normally. All of those patients I told you about, my 35-year-old, my 68-year-old, they're all walking around. Okay, they come in, I embolize them, and they actually go home the day after. So 24 hours after, the lady with the breast cancer, she went home the same day. Okay, all I have to do is stick a needle into their artery. They have to recover from the hole in their artery, and they go home. They get something called post-embolization syndrome, where they feel like they have a bad case of the flu for about a week, and then they're fine. Okay, they're tired from the tumor, and tumor can really exacerbate you, but they don't feel like they do when they get chemo. They don't lose their hair. Very rare instances that we've seen patients lose their hair, but they usually don't. Okay, they feel great, which is why I love my field, because I can treat cancer, but patients walk out. Okay, when they're on the table, they're talking to me. So these patients do phenomenally well. Okay, but they have to respond, and as you've seen, some patients don't respond. So this lady was a responder, and we were really, really pleased. She went in and she had her tumors resected, and then we got this Octria scan. Does anyone see anything that's, do we win? Should we pat ourselves on the back and go home? So no. Okay, so imaging failed us. This is my last example where imaging failed us. All of our imaging studies said she did not have any disease anywhere that we couldn't see. Okay, and so to your point, maybe she did. Okay, maybe she had something somewhere else, or right around one of those tumors, or right on the edge of that ablation we didn't get. So she's got recurrent disease. Okay, can we go in and treat that? We sure can, and we know she responds to our therapy. So now, what does the future hold? So this was some of the work that I was doing when I was a fellow. So ultrasound as a therapy. So what people in the world have started is using ultrasound as a contrast agent. And basically what they do is they make air and they surround it with something. So it's basically just a bubble, okay? And when you put an ultrasound beam on these bubbles, they expand and contract just because of the ultrasound wave, and they explode, okay? And that's what this picture is showing you. Well, tumors, as you can imagine, their blood vessels have to grow really fast. And so when they grow really fast, they're not tight, like our normal blood vessels. So they're leaky. And so when these ultrasound contrast agents expand and contract, they explode. They become nanoshards. And those nanoshards can actually make their way through these leaky vessels and get into the tumor. And you can have site-selective delivery, meaning that the drug will only be delivered where the ultrasound is put on the tumor. And this is just basically what they look like. Okay, this is the gas core. This is doxorubicin. This is just a drug that we put on them. This is what they look like after they've exploded. And this is what they look like when we've infused them. So we did this in a rat. We infused the ultrasound contrast agent into the tail vein. We put the ultrasound probe just on the tumor. We watched it come in. You can see it there. It's coming in. And then we measured how much doxorubicin actually got to the tumor. And it actually did deposit right in the tumor. So how neat is that? I don't even have to make a puncture into the artery. I can just give it by the vein. Okay, so that's something else. Another group here in 2008 decided, how can we get drug to go where we want it to go? So they coupled drug to iron. And then they infused it systemically. And they put this animal in a magnet. And they just basically put the magnet on the liver, and they said, if we put a magnet here, do you think we can get particles to go there that have a magnetic? And it did. It responded to the magnetic field. So the drug actually went where it wanted to just because we put a magnet on top of the patient. And then nanoparticles, this is a great place for nanoparticles, and this is what we're working on now, is these multifunctional nanoparticles. So we have nanoparticles that we can see on MR, that we can make, the shell is gold, and so gold can be heated up, and we can also put monoclonal antibodies so that it can actually bind directly to the tumor. So that's what we're making in our lab now. And when you do this, you can do what's called photothermal ablation. So we talked about ablation before, freezing, burning. Photothermal ablation is sort of like burning, and if I inject those nanoparticles with that gold shell, it'll heat things up, and it'll actually improve my ablation zone. So right now, I'm sort of limited about 3 to 4 centimeters for a tumor. With this technology, I can infuse something either directly into the liver or into the IV systemically, and I can get a bigger ablation zone, and that's sort of just what it's showing you there. So I hope what I've done is showed you that imaging plays a critical role in the diagnosis of cancer of tumors, the treatment and assessing response, and that emerging technologies can improve current imaging, make treatments more efficacious, and hopefully decrease systemic toxicities. This is one of my favorite pictures. This is one of my patients. I did not show you. All he wanted to do was skydive. Okay, he had metastatic hepatocellular carcinoma when I first saw him. This was a year later. He wanted to go skydiving with his son, and he made it. He said this to me. So, no, that's my patient. I hope not with that white hair. No. Sort of blonde, no. Are there any questions?